So let's start with the why of outpatient arthroplasty, and I think we can make a compelling argument that we can do this for lower cost, as good or better quality, and a better experience both for surgeons and for patients. I think this is a real opportunity for us as surgeons to hit it out of the park. We've gone over this data. Matt showed it. If we look at 2010 data, 700,000 total knees, 332,000 hips, significant cost, $17 billion cost to the healthcare system for these total joints. And again, we're expecting significant growth up by 2030, 3.5 million total knees, 600,000 total hips. I think it's clear that we need to find cost-effective solutions to manage this healthcare burden. And cost, in part, is what has driven the progression from the hospital to the surgery center for many procedures: arthroscopy, ACL reconstruction, rotator cuff, spine surgery, uni knee. I've been doing pretty much exclusively outpatient uni knees over the last 2 years. And clearly that's reflected in the trend shown by this curve. Over the last few decades, we've seen a significant increase in outpatient procedures and a decrease in inpatient procedures, and I think this is going to carry over to the total joint world. Clearly, we see that cost is less in a surgery center setting, and just a couple of non-orthopedic but incredibly common procedures, colonoscopy and cataracts, you see that it's roughly half the price to do this in a surgery center setting. A recent OIG report mentioned that billions of dollars could be saved if outpatient procedures that were performed in the hospital were billed and charged at ASC rates. So clearly the ASC is a cost-effective mechanism for the delivery of care. And this carries over to total joints as well, and we've had some recent publications in that regard. This study from last year looked at 119 outpatient total hips over the last few years, and you can see the cost was $24,000 versus $31,000, no change in complication rates. Low-volt study from 2 years ago looked at cost as well. Outpatient total joint saved $8,500 versus a standard inpatient stay. So as these cost numbers come around, we see that there's projections of significant growth in this. This is a healthcare consulting company looking at their growth estimates, and you see the significant rise in uni knees that we've talked about. 250% increase in volume is expected, in the next few years. 240% increase in total hips, 142 in total knees, and 100% or doubling of the shoulder arthroplasty growth. So significant growth is expected. And just as an aside, in this era where patients are paying more of the bill, cost transparency is an important thing as well. This was an interesting sort of survey that a healthcare consulting company did recently and showed that it took 3 times as many phone calls to get a price from a hospital, and it takes 4 times longer to actually get a price from them. And patients more and more are asking, what is this going to cost? Clearly they can get a more clear answer from a surgery center today. There are critics that say the hospital's a safer place to do these procedures, and I'm not sure that's the case. You look at this recent Journal of Patient Safety article, more than 400,000 premature deaths per year in the U.S. associated with preventable hospital errors. There was a recent chart review, 4,200 hospital records were reviewed, and they found 21% incidence of serious adverse effects in the hospital, 1.4% of lethal adverse events. I think we can make an argument that the surgery center has high quality, comparable or better than a hospital. We are able to assemble specialized teams. We truly have physician control that we don't have at many hospitals unless we own them like Ken does, but I'm not in that situation. A lot of us are not. There's more accountability at a surgery center setting, in my opinion. And I think sometimes resources are more available in that setting. I have trouble sometimes getting proper physical therapy at the hospital. I have my therapist going to the surgery center on demand. I can't get liposomal bupivacaine at any of my hospitals. They won't pay for it. I use it in every arthroplasty case at the surgery center. The quality question has been looked at in a number of studies. Study from 2014, 160 outpatient uni knees, high patient satisfaction, no readmissions, so high quality. 2012, 24 outpatient unis, high patient satisfaction, again, no readmissions. Berger study 5 or 6 years ago, 24 of 25 patients with uni knees discharged the day of surgery. So that's uni knees showing clear safety and quality there. What about outpatient total knees? The low-volt study, again from 2 years ago, showed that compared with outpatient surgery, inpatient care was associated with a higher risk of infection and a greater risk of knee pain and stiffness. And Frank Kolesek's article from several years ago showed no increase in complication rates for outpatient, which was a 23-hour stay versus inpatient surgery. So again, I think the quality is there. And in total hips, Berger's study looked at 150 outpatient total hips, only 1 readmission, 9 ER evaluations within 3 months, but the conclusion was that outpatient total hips can be safely performed. Dorr published an article showing 96% patient satisfaction with outpatient total hips. So I think the quality is there. What about the experience? And this is not only the experience for the patient, but the experience for the surgeon. Clearly for the surgeon, boy, it's nice not having a CPOE person over my shoulder telling me what I need to do with computerized orders. My experience doing these cases is great in the surgery center setting. I can assemble a dedicated team. It's highly efficient. I have more control over the process. There's less bureaucracy. And from a patient perspective, I really think we're better able to script the experience for patients in the outpatient setting. So we've answered the question why. What about the question who? Who do we do these procedures on? And I think that there are patient factors and there are insurance factors that we're still working through. But in general, from a patient standpoint, we need a healthy patient, a motivated patient, somebody who's interested in the outpatient concept. If somebody's afraid of it, I discuss the situation with them, give them some of the information that we've just discussed. But we need an interested patient in this concept. They need to have a proper home environment with family support, appropriate physical environment. Now, there are ways that we can measure this. There are some patient assessment tools. This is a basic one, more targeted towards the inpatient stay. But it asks questions. What assistive devices do you use? How far can you walk? And we try to stratify patients in terms of where they can go after this procedure. And there are some more sophisticated tools under development that look at this to see if patients are candidates to have this procedure as an outpatient. It isn't for everybody. Certainly there are contraindications, cardiac conditions, pulmonary disease, high BMI, history of GI issues such as post-op ileus, liver disease, anemia, maybe a history of urinary retention, neurologic issues. So certainly it's not for everybody. And the critics, again, will tell you, well, look at this study. This is Parvizi's study from 2007. 6% of total joint patients had major complications, and most were in the first 4 days, as you can see outlined on this graph. The risk factors were older age, higher BMI, higher ASA scores. So the argument may be said, well, let's keep these patients in the hospital for 3 or 4 days so that we can pick these complications up. And I kind of look at it a different way. I would say instead of focusing on the 6%, let's focus on the 94% of patients that don't have major complications. Let's try to tease those patients out of the population and bring them into an outpatient setting. As far as insurance issues goes, we talked about the fact that from a Medicare standpoint, uni knee is designated as an outpatient procedure, so there's no problem there. They have not yet approved total hip and total knee as an outpatient procedure, so there are no surgery center codes for those as yet, but I think that they'll be coming. From a private payer standpoint, you need to look at appropriate coverage for the ASC. You need to look at your contract specifics, including implant reimbursement, as you look to move into this space. You may need carve-outs for total joint codes and look at bundled payment options. We, in fact, today have an Aetna carve-out going into place as of May 1st, and we're just about to ink a bundled payment with Blue Cross. So these are things that are part of the process as you work into this. And a lot of people are starting to work towards outpatient total joints. At the Academy about a month ago, I went to the Outpatient Total Joint Symposium, and they did some audience response data. 24% of the people in the audience have performed outpatient uni knees, 12% have performed outpatient total knees, 11% total hips, and 12% shoulders. So while they're not incredibly high numbers, it's not like it's the rare place that is doing these procedures. So what about how? And I think we need to look at pre-op, intra-op, and post-op factors. Pre-op patient selection is important. Patient education, I think, is critical. Discuss the program with the patient, discuss their expectations, and over-communicate with them. We have just an example here of what we give patients, or one of the pieces we give about partial knees, so that everything is scripted for them ahead of time so that they know what to expect. Medical clearance is important, but I really think it's more medical optimization. We're trying to make sure diabetes and those sorts of risk factors are under good control. I think prehab is important. We send all of our patients to our physical therapists ahead of time. They get some strengthening exercises, they get assistive device training, they get their DME, and this patient who's getting up at the surgery center after his total hip already knows this therapist. They've already worked together before the day of surgery. I think pain management starts pre-op and goes through the post-op spectrum. And a multimodal approach is important. Most of us are familiar with this. The concept is that since pain transmission and modulation occurs at multiple sites, and since various analgesics work at multiple sites, that an approach to pain management should focus on more than one modality. And that concept was introduced over 20 years ago. The other concept is preemptive analgesia, which I think is important, and that's a concept of administering analgesics prior to the painful event to decrease sensitization and excitability of the pain pathways. So our sort of pre-op medication protocol is an anti-inflammatory, a narcotic, Tylenol, and Zofran. And all my patients get some combination of those medications ahead of time. Decadron is another useful tool that I've instituted within the last year or so. It's a high-potency, long-acting steroid. The literature supports its use in decreasing pain and nausea. There's been some concerns about side effects that have limited its use, but this is a great study from a couple of years ago. Looked at 120 total hips and total knees, 2 doses of Decadron, and they found less pain, less nausea, better ambulation, decreased length of stay with Decadron. Intraoperatively, there's anesthetic, surgical techniques that are important. From an anesthesia standpoint, I think there's plenty of options. A spinal or a light general works. Blocks can be helpful, but the key is to minimize side effects. Decrease nausea with prophylaxis, hydration, and minimize the narcotics. And from sedation standpoint, minimize the narcotics as well. From a surgical technique standpoint, I think less invasive is preferable. Efficiency is important. You don't want to do a 4-hour outpatient total hip. This is a direct anterior hip at the surgery center. Minimize the blood loss. I use TXA in all my patients, including uni knees. Some of it I think is psychological. A patient wakes up after a total hip with a small dressing, no drains, they're getting up and they're moving, and I think that there's some psychological effect to the positive for those folks. I use local injections, liposomal bupivacaine, as outlined there, 20 cc's and 40 cc's of normal saline, and it's a tissue injection, not a joint injection. So how do you get started? I think you start by making protocol changes on your inpatients. You start to shorten their length of stay like Ken was talking about, and start changing patient expectations. But for us, a good place to start a couple of years ago was with the outpatient unis, and once we got comfortable doing those, we've transitioned to the outpatient joints with good success. There's an outpatient uni at the surgery center. One other point is it's important to know your own state regulations. There are differences. In Florida, we're a same-day surgery center law. We can't keep people overnight. So for us, surgery center-based total joints are going home the same day. There's states with 23-hour stays, and there's some states that have a recovery care center type of approach where you can set up a facility for 2 or 3 days. So you need to know your own state licensing regulations. So I think outpatient total joints are here to stay. I think significant growth is to be expected. It's cost-effective, and I think safe with the correct patient selection.